Hello, my name is Courtney Breen, and I'm going to talk about ROHHAD and rare pediatric disorders through the lens of social work. I am sharing from the dual position of both a social work graduate student researcher and a bereaved parent of a child who was diagnosed with ROHHAD. This lived experience shapes my understanding of rare disease and my engagement with this research in profound ways. My positionality informs my commitment to seek systemic change to improve outcomes for children affected by rare pediatric disorders. Through an anti-oppressive lens, I recognize that my position includes both marginalization and privilege. While I have experienced marginalization with systems that are difficult, my whiteness, citizenship, and English fluency offers me protection not equally available to others navigating the healthcare system. And I remain humble to the limits of my perspective while being committed to anti-oppressive practices. For this presentation, we will examine ROHHAD with the intention of contributing to the broader understanding of rare pediatric disorders. We will consider the impact on patient and families from a holistic perspective and how the healthcare delivery system impacts patients' experience. Lastly, we will take a look at rare pediatric disorders through the lens of social work. It's a lot of information in a short amount of time. Here we go. ROHHAD is an acronym. RO for rapid onset obesity, H for hypothalamic dysfunction and hypoventilation, and AD for autonomic dysregulation. It's an ultra-rare and complex disorder with only around 200 known cases worldwide. Patients with ROHHAD often, one of the first symptoms is rapid onset obesity. So nothing else has changed in their lifestyle, but they gain a considerable amount of weight in a short amount of time. According to the National Organization for Rare Disorders, they explain it as a disorder of respiratory control and autonomic nervous system regulation, or ANS regulation, with endocrine system abnormalities. So because respiratory control is part of the ANS, and that's in charge of changing breathing patterns in response to activities of daily living. So in ROHHAD patients, somebody without ROHHAD, if they're exerting more energy, your ANS would increase your breathing rate to bring more oxygen to the bloodstream. In patients with ROHHAD, that doesn't automatically happen. ANS is part of the nervous system that also regulates and controls other automatic involuntary body functions, including blood pressure, breathing rate, heart rate, bowel and bladder control, temperature regulation, and more. And all of those can present as symptoms in ROHHAD. The hypothalamus is what regulates the endocrine system, and that affects how the body produces hormones that control energy, water, salt, and electrolyte balance, growth, and response to stress. Again, all of those symptoms are present in ROHHAD. What all of this means is that the part of the brain that we can think about and have control over still works. So patients with ROHHAD still have the control to think and talk and move, but the non-thinking parts of their brain don't work properly, such as the example that I gave, how many breaths to take in a minute, or their blood pressure can increase or decrease, and things like sodium and electrolyte and water balance, those can all not be controlled well. So while ROHHAD disorder is rare, the rare disease community is much larger. Rare diseases are defined by affecting fewer than 1 in 2,000 people in any World Health Organization region. With more than 7,000 kinds of rare diseases, that means approximately 300 million people live with a rare disease. 70% of rare diseases present in childhood. 95% lack approved treatments. The average time for an accurate diagnosis is 4 to 8 years. And 30% of children with a rare disease die before 5 years old. So again, while I'm sharing through the lens of ROHHAD, these experiences are shared across the rare disease community. ROHHAD impacts multiple body systems, requiring a high level of care from multiple providers. This results in frequent medical appointments, which affects school for the child and work for the parent, and impacts the family as well, because a lot of time is spent on not only managing symptoms, but managing the care coordination as well. The patient is impacted emotionally and psychologically because they are stuck inside a body that doesn't work the way it's supposed to, and that's scary and that's stressful. ROHHAD can look very different from patient to patient, and there's no typical timeline as to how this disorder is going to unfold over their life. So it's impossible to know what to expect from the course of this disorder. Some disorders have a very clear timeline, and that makes it a little bit easier to care plan, but ROHHAD lacks an understanding of that timeline. Because of insufficient information available about their rare disease, it means that there are few treatments or management options are available to contribute to psychological distress and to help their physical symptoms. There can also be visible symptoms associated with disease, and that can result in social discrimination. So how might the healthcare delivery system impact the patient's experience of ROHHAD or of a rare disease? Again, because of insufficient awareness and information on specific rare diseases within healthcare institutions, it can result in a patient's symptoms being invalidated, and therefore schools and employees can fail to address accessibility needs without a proper diagnosis. This makes it extremely difficult to create goals of care because the goals of care are always going to be shifting as the child's condition changes over time. Some important aspects of healthcare delivery include care coordination to identify and remove barriers, coordination for ongoing care from multiple providers, and most importantly, self-determination for patients, that the children and their families are not only at the center of care, but they're the ones guiding the care that they receive. All of these aspects can influence how the patient experiences care, and also the impact of the lifestyle changes as a result of the disorder. Our healthcare system is more adept at treating single conditions rather than multiple chronic conditions, and that frequently results in fragmentation of care and a lack of service coordination. One thing that's very important in rare disease is creating goals of care. And that means the values and hopes that reflect that knowledge that will guide how you make decisions for your child. They could include things like seeking a cure or a life-prolonging treatment, or ensuring your child's comfort, supporting their ability to enjoy life, or spending as much time as possible at home. Having clear goals of care, even if they evolve and change over time, gives patients and their families a sense of control and confidence, and helps ensure that the child's care matches what you believe or what the families believe is best for them and their child. This slide provides some very helpful questions that can be asked of families caring for a child with rare disease, and the answers to these questions can help guide the goals of care. I just want to go back to this one. There's an extremely helpful resource called Courageous Parents Network, and that's where these questions came from. And it's important to know a family's understanding of the child's condition and how much information do they want or need about their prognosis. And the answers to these questions also help providers understand what families need for decision making. Some families might want to have these kinds of conversations, and others might want to avoid them, and it's important to be respectful of the family's comfort level. In thinking about sociocultural factors and how that impacts the patient's experience of the illness or condition. Disparities in the U.S. healthcare system are evidenced by indicators of cost, access to, and quality of care. The Institute of Medicine defines disparities in healthcare as racial or ethnic differences in the quality of care that are not due to access-related factors or clinical needs, preferences, or appropriateness. Disparities refers to lower quality care or poorer outcomes and may result from patient-level factors such as mistrust, provider factors such as stereotyping or prejudice, or health system factors such as lack of insurance coverage or underinsurance. Social and political factors can also influence disparities as well. In thinking about health disparities in the context of social justice, it's extremely important to note that differences in health among minority populations are often associated with factors beyond individual control. Disparity not only means difference, but it also implies inequality. The root cause of health disparities are systemic and institutionalized, evolving over decades or even centuries. The root cause of health disparities are multifactorial and directional and require intervention at every level. Social factors regarded as determinants to health include, but are not limited to what is listed here: socioeconomic status, transportation, housing, access to services, discrimination by social grouping, such as by race, gender, or class, and social or environmental stressors. So in thinking about the biopsychosocial assessments for a patient with rare disease, social work interventions are designed and developed with consideration to the psychodynamics of the individual, as well as the specific characteristics of the illness and its effect on the patient. Using the social status examination in healthcare is a model that recognizes health and social conditions as mutually affecting each other, and management of an illness is a social process. Using this tool allows social workers a foundation for determining the current status of a patient and identifying potential services and intervention. Some important things to consider prior to a biopsychosocial assessment is where the patient is in the diagnosis process. Are they still currently seeking diagnosis? Have they been recently diagnosed? How long have they lived with their disease or disorder? Will they be losing capabilities as a result of this disease, or have they already lost certain capabilities? The answers to these questions can help guide the biopsychosocial assessment. Again, Courageous Parents Network has excellent resources, and they even filter them by the phase of where the patient is. Are they orienting toward a diagnosis? Are they navigating a diagnosis? Or are they moving forward? It's really important to understand baseline in rare disease. And again, I'm using CPN, Courageous Parents Network, to share the questions that they have come up with to help track baseline. And baseline is what a patient's normal looks like. Some rare diseases will change over time, and symptoms will present differently over time. This changes what the patient's baseline or normal looks like. CPN defines baseline as the starting point that providers can use to measure physical, developmental, and mental health. Baseline is the point of comparison as changes occur. And it shifts over time as the ups and downs continue. The ups might not go as high as they once were, and the downs can lower over time. The lower steps can represent a lower level of functioning. And understanding shifts in baseline are tied to the goals of care, and that changes in baseline are an opportunity to reconsider goals and if they need to be modified. Sometimes acute events occur, which brings on the need to make quick and difficult decisions. And this is where understanding what a family's priorities are ahead of time is going to be the most useful tool for guiding choices and decision making. One major task for parents of children with rare diseases is to aid the child in coping with his or her condition while simultaneously managing their own worries as the parents. Issues of parental control include, So this list here is what social workers should be aware of and take special consideration of while working with a patient experiencing rare disease. So, and these are things that you wouldn't be aware of unless you have experience with rare disease, either as a caregiver or as a provider. And these are things that the families will need support in as their child lives with rare disease. If you are a provider supporting families with children with rare disease, I encourage you to check out CPN, Courageous Parents Network. There are resources that are specific for providers, but I also encourage you to check out the parent resources. There's checklists, videos, interviews with both parents and providers to get a glimpse of what these families are facing. Thank you for your time, and I sincerely hope this was beneficial, and I look forward to your questions and comments. Thank you.